So thanks for everyone for joining us. Before we begin, I'd like to acknowledge and pay respects to the traditional custodians of country throughout Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Wadawurrung people, and pay my respect to their elders past, present and emerging. And I also further acknowledge the traditional owners of the land on which you are on and pay respect to their elders past, present and emerging. So today we've got Alana, who's going to present on shared decision-making in mental health and alcohol and other drug use conditions. And hopefully everyone saw the email that you sent around previously and had to think about those questions about how people might make medical decisions. So when you're ready, take it away.
Thanks, Matt. So just based on what I sent around yesterday, I wanted you to just have a think about a time fairly recently so that you can remember the interaction when you made a decision about your healthcare. And it can be any aspect of healthcare with either a medical doctor or other clinicians. So it might be a psychologist, it might be a nutritionist, it might be a pharmacist, things like that. So keeping in mind that decision, I want you to think about how you went about making that decision with your clinician. Did you just simply go with your doctor's recommendation or advice? Did you make the decision together with your doctor? Or did you make the decision by yourself, largely independently of the doctor or clinician? So what I'd like is just to do a quick poll. So if you could put in the Q&A just the number 1, 2, or 3 that best corresponds with how you made that healthcare decision. And we'll see if we can get an idea of how people are making those decisions. Okay, we have 1. Any others? Great. Okay, any final responses? Yeah, okay. So we have some people sitting between numbers. Okay. Perfect. Okay, so we seem to have a bit of spectrum of decision-making involvement here, which is what you might expect. Sorry. Okay, so if we think about 1, that's really, I guess, the traditional paternalistic approach to decision-making, which is largely led by the clinician. At the other end of the spectrum, we have patient-led or autonomous decision-making. It's also called informed choice, but I think that that can be somewhat misleading. And then in the center, we have what's known as shared decision-making. It might also be called collaborative decision-making, but shared decision-making, I guess, denotes a specific approach and model, really. And as I guess was evident in some of people's responses too, is that it really is a continuum. So you may be sort of leaning towards patient-led decision-making with some input from the clinician, or, you know, it's largely clinician-led with some more input from yourself. So in terms of defining shared decision-making, it's a process whereby clinicians, patients, and more increasingly others are involved, such as family, working together to make a mutually agreed upon healthcare decision based on clinical evidence and the patient's informed preferences. So the core components to shared decision-making really are that both clinicians and patients are active participants in the process, that it involves a two-way sharing or exchange of information and knowledge, and that the final decision really integrates and reflects both the clinicians and the patient's preferences in terms of the course of action. So if we think about the 3 predominant models of decision-making, we have the paternalistic, the clinician-led, and then the autonomous, and then in the middle, the shared. And it really was in the late 1990s that a model of shared decision-making was developed by Charles and colleagues. And this remains the predominant model or approach to conceptualizing shared decision-making. And all 3 of these models center around 3 main decision-making stages, which is information exchange, deliberation, and then finally deciding on an option to implement. And where these models really differ in terms of the information exchange is the characteristics around the flow of information, the direction of information flow, the type of information that's shared, as well as the amount of information that's shared. So as you can see in the paternalistic and autonomous model, it's largely the clinician who's giving that one-way information. Whereas in the shared approach, it's more of a dialogue between the clinician and the patient. In the paternalistic model, it's really just clinical information and the minimal amount of information that's legally required. So in a way, I guess it is a bit more like the kind of traditional approach to getting informed consent for, say, a procedure. And whereas in the shared and autonomous, there's a more holistic sharing of information, both clinical and also personally relevant information. And then that's all and then we move down to deliberations, so considering the options. In the paternalistic model, it's largely the clinician's role to do this. In the patient, it's largely the patient's role, so the clinician's really just there in terms to feed the information, and then the patient goes off to make the decision by themselves. Whereas in the shared, it's clinician and the patient together, and again, recognizing the potential role of others. And then finally, deciding on an option to implement, so making a choice, and it's reflected similarly there as in deliberation. Okay, so I guess that all sounded good in theory, but I guess people were thinking, you know, people come to situations with their own expectations and their own abilities and their own skill set, and that really there's a need to define the prerequisites in order to engage in effective shared decision making. And so this has sort of been more recent work where it's sort of the idea that both the clinician and the patient is contributing to this interaction. The clinician in terms of sharing the evidence and being able to communicate risk, as well as their clinical knowledge and skills. And the patient or the client is also coming to this interaction with knowledge of their individual characteristics and their needs, as well as their preferences and values for treatment. And so really shared decision making is, I guess, distinct from the other approaches insofar as it recognizes two experts in the room. And then there's sort of this need for both parties to actually believe in the benefit of shared decision making, be willing to participate. Obviously, if the patient's not willing to participate, then it's not going to work. And finally, also an acknowledgement that a choice does in fact exist, and that one's current preferences for a particular option may be at least partially uninformed. And then you have, I guess, compared to that, I guess, really sort of staged model, you have a bit more of a dynamic process here of activation, communication, and collaboration. And this might be a back and forth process. It may go over several consultations, depending on the complexity of the decision. And that basically the idea is that at the end of this, both the clinician and the patient come to a point of having informed preferences, with the clinician being informed about the patient's perspective and the patient vice versa. So again, kind of making this idea of shared decision making more practical and the idea of how do you actually implement this in practice, there was some work that was done by Elwin and colleagues who developed, I guess, a practice model for shared decision making. And it's quite simple and pragmatic. And the idea is that initially the clinician and the patient engage in what's known as choice talk. And this is really, the purpose of this is actually to increase awareness of there actually being a choice and pointing out that there are a number of available and clinically viable options to choose from. And then you move on to option talk, which is information sharing, sharing of knowledge, sharing of expertise on the various options that are available. And then you have a process of deliberation. And the reason why I've put it like this is that this process may actually go over time. It may be an ongoing process. It may go on between consultations. It doesn't necessarily happen in the consultation itself. And this is whereby people are considering the positives or the negative aspects of treatment, and actually considering what's most important to the patient. And this might be a point at which the patient involves others in the decision-making process, such as family members or their partner, for example. You then sort of have the next component, which is preference or decision talk. And so this is where preferences are actually discussed and checked. And this is all parties' preferences. And then kind of, I guess, moving towards deciding on the best available option. And then finally, actually making a decision. And it should be noted here that a decision can actually be to postpone a decision until a later date if it's not urgent. And this may be the case in a number of, I guess, chronic illnesses as well, both physical and mental health. Or it can be to maintain the status quo. So actually to consciously and deliberately decide not to do anything at this point, to perhaps watch and wait and see whether things progress. So I wanted to give you an idea of what shared decision making might actually look like in clinical practice. And this is actually in a general practice setting. And it's someone making a decision about their diagnosis of depression. And the reason why I've used this particular example is there's actually not that many video examples of mental health shared decision making that you can see. There's also kind of these off-sided barriers to actually enacting shared decision making in the general practice setting. And I guess this really demonstrates the fact that it is feasible. And finally, I also chose it because it's actually a co-production between actual real-life clinicians, general practitioners, researchers, and people with a lived experience of mental health. It is a little bit long, so I will just jump forward and may have to cut it short as well.
Okay, so talking about this in a bit more detail and listening to you today, John, I'd say that you probably have developed what we would call depression.
Well, depression's really serious, isn't it? Isn't it incurable?
Well, I think it's serious in the sense that it's really mucking up your life at the moment. It definitely is not incurable. Maybe 1 in 5 of us in our lifetime will get depressed. So it's very common for people to get depressed or very low, okay? But there's actually quite a lot that both you and we together can do about it. So it's definitely something that we can hope that's gonna pass. You've had a lot of strains and stresses on you, yeah. And there may be some other things that we don't yet know about. But there's definitely some options for how we can work with this and how you can get better. I'm wondering, would it be helpful to look a little bit at what your choices are in terms of, treatment for this?
Well, I want to get out of this rut, if you like.
Yeah.
And if you can offer me a way out, I can't promise that I can make decisions yet. I don't know if I'm ready to make decisions yet, but please do. Please offer me options.
Well, I think in a sense it's not going to be me that gets you out. We're going to get you out, okay? It's about you and me and Stacey, okay? Right. And of course the first thing is understanding it more. So I'm going to suggest I give you some stuff to read that helps explain a bit the way depression works. But also we could look at really there are 2 or 3 basic options that we've got in terms of trying to get you out of this, okay? So, I find it quite helpful to write these down. So the first option is what you can do for yourself, okay? And it can feel very difficult to do that when you feel as low as you're describing.
Yeah.
But self-help can actually be really effective, and there's quite a lot you can do in that. And that's things like activities, or it might be using a computer program to actually do some therapy for yourself, okay? So that's one set of options, and we can look at that in more detail. The next one is really talking, what we call talking therapies, so essentially talking treatments, meeting with someone, sometimes over the phone, you more often face-to-face, but whatever works for you, and spending some time understanding the situation and understanding how you might be able to get better, okay? And then the third one, which you may or may not have thought about, is medication. Is that something you...
Well, I've heard about side effects, so I'm very wary of that option.
Yeah.
But it's something I can discuss with Stacey.
Yeah, well, you're absolutely right. There's no free lunch in all of this. All of these things have benefits, and all of them have some challenges or things that you might call risks or consequences. So what we would do is look at the positives and look at the negatives, and begin to see which is the one that's going to work best for you. Okay.
Yeah.
But that's, as you say, not something we shouldn't necessarily need to rush into. You told me that you're coping. You told me that you're not suicidal. And
go ahead to a follow-up consultation.
Doctor's ready for you now.
Thanks.
okay, so John, we really got to that point where we do have, we have to make some choices about what you'd like to do to see if we can get you better.
Yeah.
Okay. Did you read the stuff that I gave you last time?
I thoroughly discussed it over with Stacey, and we took the time and effort to consider things. What worries me is that medication might take long to take effect, and the side effects associated with medication. I was thinking of leaning more towards talking therapy.
Okay, so one of your concerns about medical, or two of your concerns, if this was the thing that we wrote out last time, so two of your concerns about medication.
Okay, I'll just stop it there, but you're more than welcome. I'm happy to share the link if you want to see the whole clip. Okay, so I guess really, what is the rationale for shared decision making? Well, there's a number of different reasons, reasons that are inherent to the nature of the treatment, as well as reasons on the part of the clinician and reasons on the part of the patient. So first of all, many healthcare decisions, in fact, sort of a majority of healthcare decisions actually lack a single best course of action. So often there are at least two viable options with similar evidence and support for their safety as well. Often options have limited, or they might have mixed evidence to support the superiority of one healthcare option over others. The different options may carry different benefit or cost profiles, which different patients may value differently. So I guess if we reflect in that last clip, you know, some of the side effects were somewhat concerning about medication, whereas for other patients that may not have been such a concern. And even in cases where you have a known effective healthcare option, this option may have quite substantial adverse effects, which are likely to impact on the patient's quality of life or adherence to treatment, and so may not be suitable. On the part of the clinicians, they have an ethical imperative to ensure that patients are informed about their healthcare options, and that they have the opportunity to be involved in decision-making to the extent that's possible. And finally, most patients want to take an active role in making decisions about their healthcare. So I guess really a way of conceptualizing a way of conceptualizing shared decision making is really the union or the marriage between evidence-based care and patient-centered care. It's sort of a mechanism by which these two things can be united. So there's a number of benefits which are associated with the use of shared decision-making in the context of mental health. So this is a more of an emerging evidence-based, whereas there's sort of decades of evidence in the context of, say, things like oncology. So in adult studies, it's been shown to lead to improvements across sort of the quality of the healthcare decisions that are made, in terms of, you know, patient attitudes, their knowledge, their adherence to treatment, the severity of symptoms, and also the uptake of options that are consistent with guidelines. And also importantly, within the context of mental health too, the notion of shared decision-making can actually be somewhat empowering for the patient, and it can encourage further help seeking and also reduce self-stigma or perceived stigma by others, the idea that they are being given a voice in this context. So as I guess reflecting back on the requirements for shared decision making and also watching that clip, you can see that effective shared decision-making actually requires a number of complex skills. So the clinician's ability to communicate knowledge about the treatment benefits and risks in a way that a patient can understand and actually utilize that knowledge. And also the patient's ability to recognize and communicate their needs, values, and preferences regarding treatment. And to this second point, this can be somewhat difficult if someone's coming about to a situation for the first time. For example, you know, they find themselves experiencing symptoms of depression for the first time. They may not actually realize what their values and their preferences or their needs are with regards to the different options. So patient decision aids are evidence-based interventions which can take various forms. They can take the form of booklets or websites or apps, and they can facilitate shared decision-making by providing evidence-based and non-directional information about the available options and outcomes. And they do this in a clear and easy to understand format using both text and graphics. And important to the deliberation process, they also provide values clarification exercises to help patients to weigh up the pros and cons of options against their preferences. They're designed to support rather than replace discussions with a clinician. And I guess when sort of the idea of shared decision-making originally came around, there was this real proliferation of patient decision aids that were quite poor quality. And so sort of from the early 2000s onwards, there's been these consensus-based international standards known as the IPDAS, which ensure rigor in terms of the development and the evaluation of these aids. So I guess if we reflect back on the previous encounter, there's different points at which a decision aid could have been helpful here. So in this, I guess the clinician, being somewhat skilled in shared decision making, was able to sort of do a very ad hoc decision aid in the consultation to help with sort of discussion of choices, choice awareness, and introducing the options. And there's also the potential for the use of decision aids outside of the clinical encounter to sort of help with the deliberation and also get people to become more informed in their preferences and to be able to express these and what options they're leaning towards with the clinician. So in terms of some decision aids of some patient decision aids which have been evaluated via RCT in mental health, a couple of recent ones, there are more recent ones than this, but these ones included nice pictures. So one was designed by LeBlanc et al, and this was for considering antidepressants in the primary care setting. And this was designed to be used within the consultation. And then secondly, this was another one which was more a direct-to-consumer type online decision aid. And here you can see the, again, for considering treatment options for depression. And it was, here you can see the values clarification exercises, so people indicating how important or how much of a concern the different aspects of treatment are for them. And then finally, as part of my PhD, I developed a booklet decision aid for people considering medications and adjunctive psychological treatment options for bipolar II disorder. And that was just evaluated by a pre-post pilot, and then got funding to develop that into an interactive online patient decision-making, which was evaluated via RCT. So some findings from my RCT was in terms of feasibility and acceptability, it was endorsed quite highly on both of these things, both via self-report and also via analytics. It didn't show any adverse effects on anxiety symptoms or bipolar related symptoms, and we were underpowered to actually test efficacy, but it appeared to be potentially efficacious at improving decisional conflict, patients' knowledge about treatment options and outcomes, how prepared they felt to make a decision with the clinician, and how much regret they experienced about the choice that they made. So I guess really, in terms of bringing this across to the comorbidity setting, which is new in the space of patient decision aids at least, I remember when I was first reading through the comorbidity guidelines, which Kath and Chris developed, and there was a lot of allusions to shared decision making, not to patient decision aids as such, but to shared decision making throughout, with reference to a number of different conditions. So I guess realizing that the evidence base is incomplete, at advising that treatment approaches be client-centered, be based on evidence, take into account the client's needs and preferences, and that decision-making be done in a collaborative way. And this was really echoed throughout sort of a number of different points in relation to sort of all different comorbidities. So I guess moving on to my current project, it's to develop a patient decision aid to facilitate shared decision making for people who are experiencing co-occurring symptoms of depression and problematic alcohol use. So basically this project was a 3-phase project. And currently moving into the second phase. It's been a little bit delayed, but yeah, hoping to have completed a systematic review and a decisional needs assessment, and hoping now to develop the actual content of the decision aid. So I guess why problematic alcohol use and depression? I guess it was the fact that there are currently no decision aids in this space. Or to tackle this sort of specific severity of symptoms, and also that it's of particular relevance to Australia, with 1 in 3 treatment seekers nominating alcohol as their principal drug of concern, and approximately two of these people also having co-occurring symptoms of depression, knowing that, you know, of relevance to co-occurring conditions more generally, they result in poorer prognosis and poorer outcomes, including cost, higher self-harm and suicide, greater use of healthcare services. And so really there is a need to support informed and active patient choices, and more timely uptake of evidence-based treatments, being aware that there is a substantial delay to treatment seeking. So initially conducted a systematic review, and this was to explore the use of shared decision-making and shared decision-making interventions, of which include patient decision aids in people who have co-occurring mental health and alcohol and other drug use conditions. So this followed the basic Prisma format, so screening through various databases for published literature, removing the duplicates, and coming down to 10 studies which were included in a qualitative or narrative synthesis. So in terms of an overview of the findings in terms of people's experience of shared decision-making and the observed effects of shared decision-making interventions, we found that a large majority of people with these conditions do express a preference for for active or informed approaches, which includes shared decision-making. So more, if you remember that spectrum, more towards the right end of that continuum. And then secondly, that shared decision-making interventions such as decision aids, there were other types of interventions, were viewed as acceptable, feasible and useful. And these views were held not only by the patients or consumers themselves, but also by clinicians. And looking at the RCT findings, there were 5 RCTs which we identified, and we found positive effects across different domains of outcomes. So decision-making quality outcomes, so things like improved knowledge and improved involvement in decision-making, reduced decisional conflict. We also found some positive effects for patient treatment outcomes, so improved uptake and adherence to treatment. And finally, there was 1 RCT which showed positive effects for patient symptom-related outcomes, so related both to reductions in risky behaviours as well as symptoms themselves. So as you can see, there is still some mix. Not all studies were finding positive results on all outcomes, and there was in fact sort of one negative finding, but I guess we can't really make any finite conclusions based on it because it is a relatively small evidence base, but is promising. So moving on to the next phase, I sort of did this concurrently with the systematic review, and this was aiming to assess the treatment information and decision-making needs of people with problematic alcohol use and co-occurring depression, and did this via parallel online surveys of key stakeholder groups being patients, clinicians, and patients' families. And so I guess in order to, you'll remember back to the beginning, all those different healthcare decisions, and it's possible that a decision aid could target every one of those, or you could have a decision aid for each one of those decisions because they are designed to be designed for specific decisions. And so we really wanted to delineate here what is a common difficult decision that patients encounter when they're first seeking help, seeking professional help for their treatment. And there were 4 decisions which were identified as that are sort of the largest proportion of stakeholders identified these decisions as difficult early on in treatment seeking. And one thing that I will point out is that you can see that where we have these exclamation marks, that a higher proportion of patients than clinicians are indicating that these decisions are difficult when they're first engaging in treatment. So I guess a patient decision aid could be potentially very useful here for the patients. We also wanted to assess some, I guess, particular areas of unmet need in terms of decision support. So looking at patient levels of decisional conflict as viewed by patients themselves, as well as the clinicians who treat them and their family members. And as you can see, this sort of works where the higher scores are indicative of more decisional conflict. And so you can see that actually clinicians are indicating significantly higher levels of decisional conflict on these 2 particular subscales. And in terms of overall score, you can see that patients are borderline, whereas the other 2 are slightly higher in terms of decisional delays. So this is whereby people are unsure and don't feel especially informed or supported to make a decision, and so they actually tend to not make a choice or to delay making a choice and uptaking any option, which can be problematic. In terms of assessing patient involvement preferences, you can see that a majority of people were indicating a preference for patient-led decision-making with some degree of clinician input. And finally, we also had people reflect on their former involvement in actually making a decision. And you can see that here that a significantly greater proportion of patients than clinicians are indicating clinician-led decision-making. And this might be to do with with patients placing more value on particular aspects of decision-making and perhaps clinicians just seeing that, well, if it is the patient making the final decision, then the decision-making process has been collaborative, which is not necessarily the case. And so again, sort of unexpectedly, you can see that a greater proportion of clinicians, this was marginally significant, but a greater proportion of clinicians were indicating that patients had experienced their preferred level of involvement, whereas in the patient group, you can see that around 1/3 are indicating that they're not involved to the extent that they would like to be in making decisions about their treatment. So finally, we just asked in terms to, I guess, to guide the content and the format of a future decision aid, we wanted to ask about particular aspects of the decision aid. So in terms of how they would like this decision aid delivered, what format they would like it to take, who they felt should be involved in advising on the development of the decision aid, whether they would like to use these resources in collaboration with someone or whether they would like to use them independently, reflecting on whether they would like to use these actually outside of consultation, so when they're preparing to make a decision, or whether they prefer for these to be delivered during consultations. And finally, who was perhaps the best health professional to provide this resource, or I guess to refer their use to this resource. And the asterisks that I've put here, obviously they're not a majority of patients indicating these preferences, but the reason why I put those preferences is that they diverge somewhat with the other stakeholder groups. So I guess, not surprisingly, a higher proportion of clinicians felt that patients should have guidance in using these resources. And again, a greater proportion of clinicians than patients felt that these resources should be delivered during the consultation. So just moving on to discuss future and current directions. So actually moving on to develop the decision aid. So this will be based on a synthesis of the best available evidence, and also based on guidance both from IPDAS and other organisations which advise on decision aid development. Then be consulting with an expert working party, and that will be sort of a multidisciplinary team of stakeholders, so researchers, people with experience in developing decision aids who are external to the research group, clinicians from various different backgrounds, as well as patient and family representatives, and then using feedback from these panel meetings, this will sort of inform the iteration of drafts and then revisions, and it will go around in a bit of a cyclical process until we reach consensus. So I might just skip across, this is just the significance of my project. But just to give you, I guess, a summary and to allow a bit of time for questions, I guess, just a summary of shared decision making. It involves, I guess, the core components being a two-way exchange of information, knowledge, expertise, both professional and personal, a shared deliberation of options, and coming to a mutually agreed upon decision. It really can be seen as the union of evidence-based and patient-centered care, and it permits decisions which take into account both the evidence base as well as patients' individual treatment values and preferences. It's best suited to decisions where there are at least two viable options, but there may also, but also remembering that there may only be one, I guess, intervention per se, but then the second option may be to watch and wait, or to do nothing, for example. And this might be particularly the case in end-of-life decisions. And then finally, that it leads to a whole host of improvements in patient decision-making and treatment outcomes, and that this process may be facilitated or improved by the use of patient decision aids. So I guess just reflecting back to your own decision-making and your own involvement in healthcare, I wanted to leave you with 3 questions, and these are called the Ask, Share, Know questions. And they are, I guess, they're obviously not a patient decision aid, but they are a form of shared decision-making intervention in a way, because they have been linked to improvements in the quality and the quantity of information that's exchanged during a consultation. So they're fairly easy to remember, and I guess also thinking when you do next need to make a decision about your healthcare, to ensure that you are active and informed in that process. And one other thing to present you to, I don't know if that link will work. Oh, perhaps it will. There's actually an online repository of patient decision aids that cover a whole host of different decisions. As you can see, the decisions that they target are fairly specific, and they come in different languages. You know, it's unsurprising that the most are in breast cancer, because this is where the development of patient decision aids started. So yes, they may also be of help. So I think that is, whoops, I think that is it at this stage. So thank you, everyone. And yes, I'll hand back over to Matt.
Yeah, great. Thanks very much, Alana. That was really interesting presentation, and it was actually cool to see kind of your work from your PhD all the way now through to kind of your postdoc, and it's always really cool to see those threads weave through all those years, and it's a really cool project and amazing work. I'm having a bit of a shocker here because halfway through your presentation, my power went out. Like the whole power of my house went out. So my internet dropped out. So I had to log on as hotspot on my phone. So hopefully it'll continue to last the distance for the next 10 minutes. But if anyone has questions, please plug them into the Q&A. Also, Sophia has got a question. She says, are there many known mediators in clinician involvement? For example, demographics of the clinician and patient, how long the patient has been seeing the clinician, etc.
So not sort of mediators per se, but I guess some of the things which are associated with increases in shared decision making, there actually don't tend to be many socio-demographic factors. So they've consistently looked at social demographic factors, and they don't tend to be associated with clinician involvement, with patient involvement in decision making. And so that's really highlights the need for clinicians to actually actively elicit from patients what their preferences are for involvement in decision making. I guess some of the things that understanding the patient. Yeah, so it is linked to a stronger therapeutic relationship. So people that tend to obviously have a stronger and healthier therapeutic relationship are more likely to have experienced shared decision making and involvement.
Cool. So Paul asked a question. The term informed choice seems to apply to model two, shared decision, as much as it does to model 3, autonomous decision making.
Yes, and that's why I tend to not use the term informed choice, because I think it's somewhat misleading, because informed choice can actually also be used in the context of share as an outcome for patient decision aids, whereby someone makes a choice which is in line with their preferences and is in line with the best available evidence. So it can be a bit confusing, but informed choice, I guess, was what it was originally termed, because it kind of came about, I guess, that approach to decision making kind of came about in the United States in the 80s, or more particularly the 90s, with the consumer involvement, with the consumer movement, and I guess it was seen to be quite empowering. So yeah, but I agree, Paul.
Cool. Katie writes, hi Lana, really interesting, thank you. Just wondering if your review and in development of the tool, you will take into consideration specific population groups, such as Aboriginal and Torres Strait Islander peoples and people from culturally and linguistically diverse communities.
Yeah, that's a really good point, Katie. I think that it is important that those groups are involved in the process, and I think that ideally we want someone who represents those groups to be a part of the expert working party and to have that representation. In terms of the culturally and linguistically diverse communities, my intention too is to also have the patient decision aid reviewed for low health literacy levels, because we do find that often people with a CALD background are kind of doubly disadvantaged, both in terms of not being native English speakers, but also tending to have lower health literacy as well, and that can be a real impediment to using a shared decision-making tool.
Definitely. Tara writes, great presentation. Thanks, Alana. Do you think the onus to initiate conversations about SDM should come from clinicians? As your research showed, who is currently initiating these conversations, more clinicians versus patients?
Yeah, that's a really good point, Tara. And I think when you're developing interventions, ideally you want those interventions to be targeting both the patient and the clinician. So I guess you would want, really you want a multi-component intervention where a patient decision aid would only be one component, and that would be supplemented by clinician training, learning to actually use the tool, learning to actually engage the patient through question asking, through communicating risk, things like that. So yes, ideally you want to be targeting both the clinician and the patient.
Cool. Erin's got a question. She asks, is there any literature addressing how to talk to patients who try to incorporate medical misinformation as shared decision making?
Yeah, that's a good point. I think that in terms of certainly in terms of the development of patient decision aids, that should be based on, the best available evidence that's available, and also, in instances where perhaps high quality evidence isn't available, actually making that explicit to patients. And I guess also to, medical misinformation, that can also be a health literacy concern as well. So the ability to actually process information and use information. And so I guess that's also on the part of clinician education too, of patients. So yes, it is an issue.
Cool. I've got one question. I was just thinking about the kind of the decision aids that you're talking about and the efficacy of those decision aids. Has there been any studies that have looked at the efficacy of decision aids that might differ depending on whether there might be different symptoms present in people with depression or bipolar, particularly those that have kind of impaired cognition or trouble with decision making in general?
Yeah, so they have actually, there have been a number of trials, or a few trials at least, which have looked at patient decision aids in the inpatient setting. And so people with perhaps more acute or severe symptoms. I think that is often a barrier to implementing shared decision making, in that people can sort of be thought to have impaired decisional capacity, and for the most part people are able to be involved to some extent, and I think also in those situations where people do have acute symptoms, it is also perhaps involving them in a process of shared decision making for, say, agenda setting or sort of advanced care planning and things like that, so that if they are acutely unwell, they have still had some involvement and expressed their preferences.
Yeah, definitely. Cool. All right. Another question from Kylie. She says, I'm not entirely clear on the differences between shared and autonomous decision making. It seems like both incorporate obtaining information from a clinician, but ultimately you make the decision. Is that right? And if not, what differs in the shared decision making process?
Yeah, sure. So I guess the key differences really are in terms of, if you think back to that original table, the information flow, I guess, in autonomous decision making, the clinician's role really is just to inform the patient. So to inform the patient about the options, the known benefits and risks, and things that they might want to consider. But there isn't necessarily room for the patient to then have a dialogue with the clinician about what's important to them and what matters to them. That process is done largely separate from the clinician. And then obviously there's instances where autonomous decision making sort of isn't practical, because at the end of the day, it is the clinician which is going to write off on a script or something. But I guess one thing might be going against, medical advice. The clinician is telling you the options, making sure that you're informed. You might then deliberate on those options, but then you make a decision largely independently of clinician advice.
Cool. Okay, well, it's pretty much right on 3 o'clock. So I just want to thank you for presenting. It's really, really interesting stuff, and I look forward to reading more about it in those papers that are coming out shortly. So thanks a lot, and I'll go see if I can restore the power to my house. Thanks a lot, everyone.
Right. Thanks, everyone.
See you later.
Bye.
Bye.